Hello and welcome everyone to tonight's webinar, brought to you by the Capital Health Network, Canberra Health Services and the ACT Health Directorate. Tonight's webinar is on the new laws in the ACT to protect the human rights of individuals born with innate variations in their sex characteristics. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respects to the elders past and present. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. I'm Dr. Leonie Harcourt, a GP advisor at Capital Health Network. Also with me tonight is the events lead at Capital Health Network, Karnal Mohiti, Roxy Swart from the ACT Health Directorate, Dr. Michael Rosier and Alyssa Roberts from Canberra Health Services. And just a few things before we start. So usually with our webinars, we save all our questions and answers up for the very end. But tonight we thought if you type them into the Q&A section on the Zoom box, not the chat box, we'll read them out to the presenters as they come up, because that might be more relevant and more useful for all the audience. And the presentation itself will be uploaded to the Capital Health Network YouTube page in a couple of weeks. So for the GPs in the audience, at the pointy end of the year, this is worth 1.5 hours of educational activities, and please feel free to complete the post-event evaluation survey, and we'll send you out a certificate of attendance and you can upload it to your CPD home. And also just a reminder about Health Pathways. So the Health Pathway website is free and really useful, and it's got advice on investigations, treatment and referral pathways of many conditions, including variations in sexual characteristics. So if you type that into the search on Health Pathways, it'll come up about the new laws and referral pathways. And so the login for Health Pathways is the word together, all lowercase, and the password is forhealth, FORHEALTH, one word, all lowercase. So now over to the speakers for the night. I'm going to introduce all the speakers all together, and the two people presenting are Roxy and Alyssa, and Michael's going to be on hold for any medical questions that you may have throughout the presentations. So a little bit about Roxy. So Roxy Swart is an assistant director in the LGBTIQA plus health policy team at the ACT Health Directorate, and focusing on policy relating to people with innate variations in sex characteristics. Roxy has extensive experience in health in both a policy and clinical capacity, including working as a pain physiotherapist both in public and private settings. They are also engaged in research at the University of Queensland to develop patient-centred models for LGBTIQA plus people. Our second speaker is Alyssa Jacobs. Alyssa is a clinical psychologist and the acting director of allied health with women, youth and children at Canberra Health Services. Alyssa has spent the last 24 years primarily working with children who have chronic conditions and their families since obtaining a master's in clinical psychology from ANU in 2000. Alyssa continues in this role providing services to children and adolescents at the Centenary Hospital for Women and Children. And lastly, we've got Dr. Michael Rosier. So Michael is a paediatrician who's provided paediatric services to the Canberra community for over 34 years. He has worked both at the Canberra and Calvary hospitals and continues to work in his private rooms at the Calvary Clinic. During this time, Michael has dealt with a broad spectrum of paediatric issues with patients from birth through until 18 years of age. So over to the presenters, and Roxy is going to kick it off. Thanks, Roxy.
Thanks, Leonie. So yeah, as Leonie said, we've got Dr. Michael here just to help with any medical questions that Alyssa and I can't field. But we'll jump straight into it. And I do want to thank you, Leonie, for the acknowledgement of country. I just want to add that we'll acknowledge others that might be listening in to this webinar later on YouTube from lands other than Ngunnawal country, and extend that respect to other countries where our voices are being heard this evening. I also just want to acknowledge the lived and living experience of people with innate variations in their sex characteristics. I recognise their right to self-determination, and I extend that respect to intersex people here today, elsewhere, and no longer with us. Now, here are the learning objectives that we're going to go through, and it is quite wordy. My background is not in law, and so diving into this stuff over the last year has been a very steep learning curve. So I can certainly understand that coming from a clinical background as GPs, that this might feel somewhat overwhelming. I am not going to spend a whole lot of time explaining what I guess primary and secondary sex characteristics are, assuming that a lot of that is assumed knowledge. But there are some really key definitions that we do want to get into to make sure that the scope of the legislation is clear, and making sure that we're applying a human rights approach as we go through the legislation. Alyssa's going to jump in a little bit later and tell us about how to apply for these different treatment plans that we have, and then knowing the professional and legal obligations that you may have as primary healthcare practitioners under the legislation as well, and bringing it all together at the end with knowing where to go for some additional information and support as well. Before we get into it, I do want to acknowledge that this is very much a learning space, that we're encouraging questions, and that we should feel comfortable leaning into discomfort and discussion through this content. The legislation, as you know, is new to the ACT and is the first of its kind in Australia. Similar legislation is new as well globally, and while there might be varying levels of comfort with the new legislation, with the content, I just want to acknowledge that we're all here today in good faith, and we encourage questions and participation throughout this session, but we do ask for mutual respect for everybody participating in the training, and just acknowledging that practitioners come to this training with unique experiences and levels of understanding regarding innate variations in sex characteristics, as well as the related legal and ethical frameworks. This educational module is designed to meet you wherever you're at in your understanding, and aims to build and expand upon your knowledge in a supportive and non-judgmental way. We will also just acknowledge, as a bit of a content warning, that this training module does address some sensitive topics related to VSCs, medical interventions, and the legal frameworks that surround them. The content may include discussions around the medical and surgical interventions, as well as the psychosocial implications for individuals who have undergone these procedures. Some participants tonight may find that these topics are particularly challenging or emotional, and we do encourage you to approach this learning experience with some mindfulness and respect for the diverse perspectives and experiences that accompany this topic. Finally, the information in this module is intended for educational purposes only and does not constitute legal advice. It's really crucial for practitioners to consult with legal professionals or relevant legal entities to ensure that compliance with the current laws and regulations are followed. Participation in this training does not substitute for legal professional consultation and should not be relied upon for making decisions in your professional practice. Now, we will jump into the meaty parts of it. And like I said, I'm not going to preach to the choir. I'm assuming that lots of GPs know what primary and secondary sex characteristics are in clinical practice. But as we'll go through tonight, and what we'll discuss a fair bit of, is that the legislation may differ somewhat slightly from, I guess, just a pure medical perspective. So it's important for us to get a sense in the blue box that the legislation defines sex characteristics as a person's chromosomal, gonadal, or anatomical sex, and it includes their hormones that are related to sex, the sexual and reproductive part of the person's anatomy, and their secondary physical features emerging as a result of puberty. So all of that stuff is important for us once we jump into, I guess, how we define the variations of that. But while that might differ from a clinical understanding, this is where the legal definition is at. When we think about our innate variations in sex characteristics, this is terminology that we use to, I guess, collectively describe instances where someone's sex characteristics, I guess the ones that they were born with or that developed from puberty, differ from the stereotypical notions of male and female biology. One of the things we, I guess, have learned over the last few years in this space is that there are closer to about 40 known variations that can impact people's sex characteristics. And so we've moved a fair way away from this idea of even a sex binary as being male and female, and that there can be lots of different things that occur, I guess, in that space of variations in sex characteristics. Again, coming back to how the legislation defines it, it is a congenital condition that involves atypical sex characteristics, includes a condition prescribed by regulation, but does not include a condition prescribed by regulation not to be a variation in sex characteristics. And if you're like me and things like regulation didn't make any sense before, I guess, delving into the legislation side of things, a regulation is a subordinate law that explains, I guess, the things that are included in the legislation and the things that are excluded. So the purposes, I guess, of this is to make sure that we're really clear in what falls under the Act in a variation in sex characteristics, anything that is atypical. The second dot point there, I'll make clear that anything that is prescribed by regulation, currently in the subordinate laws, there is nothing, I guess, that is included in that. So I guess essentially we can ignore that second part in the sense that we refer back to that first dot point, anything that involves atypical sex characteristics, but it does not include the condition prescribed by regulation as not being included. And that'll make more sense once we jump to the next slide. Things that aren't included are these 5 conditions here. So I guess these are things that with consultation, we've looked at things that are urgent and potentially life-threatening, things like PCOS that may not necessarily fall into, I guess, everyone's understanding of what a variation in a sex characteristic might be. And the last thing on that list, testes being just the singular as well. So I think what's key with this is that we have the excluded list, but everything else that falls under that original first dot point involving atypical sex characteristics is included in the legislative definition. When we think about the purpose, the function, and the scope, one thing that is really important is that this legislation only restricts medical treatments for certain prescribed people. And we'll dive into that a little bit more. But I do want to make the point that the purpose of this legislation is to protect the rights and ensure the well-being of people with a variation in sex characteristics in that medical setting. Although people with a VSC are a diverse population, there are many shared experiences as a result of common psychological pressures alongside historic and ongoing medical practices. And this act was introduced to help address common experiences like medicalization, pathologization, medical interventions, and surgery without informed consent, as well as to combat the shame, stigma, and psychosocial trauma that can impact people with a VSC. As we'll look at a little bit later, the Act functions in that way by establishing new pathways and processes to ensure that individuals and decision makers have access to adequate information and support when making healthcare decisions. The scope of this legislation is quite narrow. It only applies to people who are defined as a prescribed person and only applies to certain restricted medical treatment. We'll dive into that because it is quite wordy, but it's important for us to get a sense of, well, what is a restricted medical treatment? And I think with this, it's very important in the light blue box that we're thinking that's anything that will make a change that is permanent, reversible only with further treatment, whether that's medication, surgery, whatever it might be, or temporary if prescribed by regulation. And again, coming back to that idea of subordinate legislation, a regulation is something that is defined by the Act. And currently, the only thing that's prescribed by regulation is vaginal dilation. So one of the sticking points, I think, can be the idea of, it's temporary. It's only restricted temporary if you're applying for vaginal dilation. Restrictions really only apply to a person, as we said, who is defined as a prescribed person in the legislation, which we'll look at on the next slide. But if your patient is not a prescribed person, the proposed treatment is not restricted or impacted by the new legislation, even if it changes or alters sex characteristics. So I think with this, it's important for us to acknowledge that it's not the treatment in and of itself. It's the treatment on a person who is a prescribed person. Another thing that we'll just acknowledge here in that darker blue box is that circumcision of the penis for any individual is not a restricted treatment. Like we said, if we're defining a prescribed person, this is a person who has a variation in sex characteristics and is also a child who doesn't have decision-making capacity or an adult who is subject to a medical guardianship order. Now, it gets a little bit tricky when we're thinking about a child who doesn't have decision-making capacity. That's decision-making capacity that's in relation to a medical treatment. So We can think about applying Gillick, which I think Alyssa will talk about a little bit later, and an adult subject to a medical guardianship order that has to apply to medical treatments only. So these are the two, I guess, classes of people that we think about when we're deciding, is a treatment plan required or not. And again,
Roxy, could I
also,
interrupt? Yeah.
yeah,
So this
absolutely.
is a question.
Sorry.
So if a child has bilateral undescended testes, that would be a prescribed person with a variation in sexual characteristics.
So bilateral undescended. So
Yep.
yep. So
So,
the only excluded conditions would be if it was the singular. So
yep.
yes, if
So
it were
two
bilateral.
sides.
Yeah.
So when I went to medical school, there was the thought that if people had undescended testes, you needed to descend them because it makes them more predisposed to testicular cancer.
Mm.
Um, so is that not a consideration anymore?
And this is something that I will potentially have to throw to Dr. Rosier. I'm sorry, I
Dr.
can't see the
Rosier?
screen.
Oh, he might be muted. Let's
Oh,
unmute him.
I'm mute. I'm unmuted
Yeah,
now.
yeah, okay.
Look, the fact it goes before the committee doesn't mean that it won't be approved that this child would need an orchidopexy. And so it's just that in a case of a bilateral undescended testis, that would be something that committee would have an interest in and would want to know what workup's been done, what's the underlying issue here, what are the risks of not doing a procedure as opposed to outcomes if you do a procedure. And so yeah, going before the committee doesn't mean that child isn't going to have surgery. It would mean that the surgeon involved would apply with a treatment plan, and then it would be assessed based on that child's individual characteristics. Does that answer that question?
Yes.
I mean, it's certainly that you're right. The risk of testicular cancer is increased in an undescended testis, and so that would be taken into account by the committee. And our role here is not to be obstructionist, but to try to protect the human rights of the child and do the best thing by them, and we would take those outcomes into account.
Thanks. Thank you. Sorry.
No worries.
Yeah, thanks. And thanks, Roxy. Keep going.
thanks, Doctor. And I think this is one of the challenges of presenting this new information. We go through all of the definitions before we've even kind of talked about how the scheme itself works. So as Dr. Rosier alluded to, I guess, yeah, the idea is not that I suppose in other countries that have looked at trying to protect the rights of people with a VSC, sometimes they do, I guess, outlaw treatments entirely. This is a little bit more complex, and I guess that's what makes this legislation unique in the sense that, we do have a board, and we'll go into that in a little bit more detail later. But getting the definitions out of the way is really important, because I think if things don't apply to a prescribed person, none of this is relevant to them anyway. So it is quite a narrow focus, but that's what makes it challenging, I guess, in kind of getting to how do we get to the board and how do we submit those treatment plans. So making sense of who is a prescribed person is a really important part of that as well. Now, the question often comes up about urgent treatments, and of course, this is something that was considered when they wrote up the Act. A restricted medical treatment does not require a treatment plan if it is undertaken urgently to save the person's life, prevent serious damage to the person's health, or prevent the person from suffering or continuing to suffer significant pain. Now, what's tricky with this is there's an evidential burden on the person, the applicant, providing treatment to prove that it was urgent and necessary. But the legislation does very clearly exclude these life-preserving treatments so that they can go ahead within that necessary time frame. One thing that we'll talk a little bit about later as well is that treatments are reportable, and an urgent treatment is also, I guess, falls under those reportable requirements as well. And the reason for that is historically there hasn't been, I guess, very good data collection on what's been performed and on whom, and part of the legislation aims to get a good sense of, well, what is the medical community doing, and how can we get good numbers in the absence, I suppose, of people with a variation in sex characteristic being included, let's say, in the census. So we'll dive into a little bit more about how the reporting works later, but it is important that even if things are urgent, or if the treatment has to be undertaken very quickly, that would still be something that we need to report on as well under the Act. Now, we kind of alluded to it before. What's unique about this legislation is the function by which an assessment committee is formed, and these are experts in 5 of these areas. They meet to determine if an application that's submitted passes the legislative threshold. And the tests that we'll talk about, Alyssa's going to talk about it a little bit later, they look at aspects like, well, what are the risks and benefits of these treatments? What are the alternatives that the applicants looked at? Or how restricted might this individual be in the future if we were to do some kind of treatment now? And making sure that all these 5 elements are considered in the treatment of a child, just make sure that we're following those best practice kind of guidelines as per those international recommendations for promoting the human rights of people with a VSC. The decisions of the 5-person committee is based on a majority ruling, and the onus really is on that applicant to provide enough information in the treatment application to support their submission. The committee obviously has to be satisfied that that threshold has been met, but they can request more information from the applicant if it's needed as well. The committee can rely on any sources of information that it deems appropriate, but if those sources are used, the applicant needs to be made aware and supplied with those resources as well. So this is a bit of an overview of who makes up the assessment committee, of which gratefully Michael Rosier is one as well in the medicine category. We've gone through, I guess, the definitions and sort of how it works. And I'm going to let Alyssa talk a little bit more about how that comes into practice. And it is quite complex, but the definitions, I think, are the trickiest part, which are out of the way. So you've done well to kind of bear with me until there. Alyssa, I'm going to control the PowerPoint for you.
Thank you.
Thank you.
So we're really going to talk about now how to apply to the assessment board when you have a case that meets those criteria and falls under the legislation. So there's 2 categories. There's individual treatment plans. So these are individualized, so they relate to a specific person that you might be providing care for, and so relates to their individual medical history and the specific treatment that you would like to undertake. We've talked a bit about the general treatment plan. So the general treatment plans, they're designed to apply to an entire class of a prescribed person and relate to either a specific diagnosis or a specific treatment option. And so there's different processes involved with these. So next slide. Thank you. So for the individual treatment plans, to be able to submit an individual treatment plan, you must be a decision maker for the prescribed person. So that would be someone who has parental responsibility or is a guardian, or you're the health practitioner for the prescribed person. And the Act is quite specific, and it quite clearly outlines information that needs to be included in the legislation. So we'll have prescribed persons' details, the details of the decision makers for the prescribed person, what treatment's been done previously, what is the particular treatment that you are wanting to undertake, so what the proposed treatment plan is, and the reasons why that's been proposed, and going through the assessment criteria. So the form, there is a form online that goes through this, which is just an example there. So we've talked a little bit about the details of the applicant and the child. And one of the first questions there is that question around competency or capacity. So if you remember, we talked about the fact that for a child to be prescribed under the legislation, they have to not have capacity. So in your practice, if you're working with a young person, if you've assessed them and you feel that they have decision-making capacity, you do not have to put an individual treatment plan in. You only need to put an individual treatment plan in if you feel the child does not have decision-making capacity. So this is where it differs a little bit from typical practice. So normally, if you're, as a health practitioner, if you're looking at treatment, you would normally have a trigger to say, I want to assess for a child whether this person has decision-making capacity. And usually what you're looking for in that case is do they have capacity, and then you proceed. What in this form that's interesting, they ask for what steps have you taken to assess that the child doesn't have capacity. So you need to be able to demonstrate why or talk about what assessment you've done and how you've come to the conclusion that the child does not have decision-making capacity. So that is different from what we would normally do in paediatric care. So that just takes a little bit to get your head around and why that and how you would describe that in the legislation. So
Alyssa, there's a question there about Gillick, the Gillick case, competence and capacity. So are you able to comment on that? And I just wanted to also let attendees know that the general treatment plan template is on the health pathways variation and sex characteristics page. I couldn't find an individual treatment plan there. So yeah, sorry, Alyssa.
No worries. So this actually follows what your normal practice would be in terms of assessing capacity. So you would what we typically use is Gillick competency, which is actually a legal kind of term. And you would be really looking at the child's understanding of their condition, understanding of the treatment, the risks and benefits, how that applies to them, and how this would impact them, their understanding of impact on future decisions and future choices they might or may not have, like fertility, for example, and really being able to document and demonstrate that they have understanding for it. So the opposite of if they don't have capacity is, do they understand the risks and benefits? Do they have the emotional maturity to understand and weigh up in the future how this will impact on them? So it's not a different sort of assessment you would do. It would follow what you'd normally do. The difference is for children, we wouldn't typically be doing that unless there was a particular trigger. And for this, it's whether they fit under the legislation or not. You would need to be giving information on the past history. The way in the form it wants you to talk about the treatment that you propose is what harm would occur if we didn't provide that treatment. So what are the risks and potential harms to the young person if we don't undertake that proposed treatment? Details of the proposed treatment. What are the alternative treatments that you may have discussed? That might include deferring, that might include doing nothing, or there might be alternative treatments that you have discussed, and that relative efficacy. So being able to speak to what would be the most appropriate and why, and the restrictiveness of treatment. A really important part of the form is, and this aligns with taking a human rights approach. There's a real a number of questions that really are looking at what information have you provided to the child? What have you gone, what lengths have you gone to ensure that this young person understands their condition, understands the treatment that you're proposing, and how have you provided that? Even if they don't have decision-making capacity, you still need to have gone through that process with them, and they're decision makers, so they're the people with parental responsibility and what information, how you've gone about that, and being able to really clearly document the wishes of the child. So again, even though you've determined they don't have decision-making capacity, what are the wishes of the child? So if you've got a 3-year-old, you're probably not going to be able to document the wishes of the child, particularly sensibly. But if you have an 11-year-old, that will be different. And so you'll be able to do that. And that's really key. And again, we'll talk a little bit about this, but in terms of practice, it's being able to document in the medical record these things that you're doing that you might just be implicit in your notes that you've provided, that you have to be explicit about what you've provided and what the young person's response and understanding was to that. So we could move to the next slide.
One thing I might just add, Alyssa, is that, in the first instance, it might be unlikely that a GP will be the first practitioner to submit an individual treatment plan, but your role as a GP might involve, maybe it's the counselling around the safety of deferral or whatever it might be. The ITPs can be approved for a maximum of 3 years. So there is a possibility that a GP might, be involved in doing one of these forms if the treatment's required beyond those 3 years, or it could be even, helping determine if that child has the capacity to consent to treatment, all those kinds of, if it was the surgeon at the hospital filling out the form, you might be called on to kind of help answer some of those questions as well.
I think, GPs are part of the treating team, and often will hold that information. I do think it's important to recognise that you might be somebody who might be, the treatment might be initiated by a peds endo team, but you might be prescribing, subsequent scripts to that. And if that's the case and it's coming up to that 3-year period, you will need to go through that process. So I think given the process of going through and writing these plans, it really needs to be the clinician that who is initiating the treatment or providing the treatment, because of the detail that you need, and really clearly that process of providing that information to that person. But I can see for GPs, it's good to know the process, but you might, if you're going to be taking ongoing care and providing that. But, in 3 years, it might be that you feel that young person's got capacity to consent to treatment, and you might decide that they don't need one. So, when you're putting together the treatment plan application, you really need to be thinking about the implications for the proposed treatment, likelihood there might need to be future treatment, whether there's any further treatment options that may be limited or unavailable if the proposed treatment is taken. So if you're having surgery and that might limit fertility options down the track, that's the sort of thing that you would need to include in there. Alternative medical and non-medical options available, like psychosocial support. And I think also going through those risks and benefits of deferring or not undertaking a proposed treatment. So there's 2 parts. What's the risk if you don't provide the treatment? What benefits might be to deferring? So the risks and benefits. So it should simulate what you're actually talking to the family and the young person about in those sessions. So general treatment plans. So these, and we've talked a little bit about these, the benefit of a general treatment plan is it can be for a class of person, so a particular condition or a particular treatment. And so the general treatment plans are, under the legislation, have to be written by specific people. It can't just be anybody putting them forward. They have to be as chosen by the minister. I think also, so it's pretty clear in those general treatment plans of spelling out why the treatment plan is proposed, providing the evidence, so clearly documenting the clinical guidelines, evidence that's there, and the evidence must apply to all those people in the prescribed class. So there's a different process that actually this needs to go for public. People will actually be able to comment on this. And so it's a different, bit of a longer process and quite, I think, more involved than doing individual treatment plans. But it's quite useful going forward, I think, for us to be working and providing some of these.
Could I just be a devil's advocate here? It does look like there is a fair bit of work in putting together a proper general treatment plan with all the evidence and everything like that. It's not a 10-minute consult.
It is not.
And as most private GPs, you know, we do private billing, so we're not on a salary. There seems like we want to do the best by our patient, but we might be doing, you know, an hour or an hour and a half or 2 hours of unpaid work to do this properly.
I'm happy to field this one, Alyssa. So the people who can submit a general treatment plan are specialist members of like the endocrinology college and very specific specialists that have been prescribed by the regulation. It wouldn't be in practice a GP we would be expecting to submit a general treatment plan just because of the volume of work that's involved. But as Alyssa mentioned, there is that period of at least a 30-day public consultation period. So I guess if one were submitted by a specialist, it goes on the ACT government website, and general practitioners would have the chance to contribute any kind of evidence in support of a general treatment plan. And that information then also goes to the board as a part of that application process. So it wouldn't be something that you're required to do a general treatment plan for your own individual patient, but it could be something that if you're interested in supporting with research or anecdotal evidence or whatever it might be, that can be something that GPs can submit in support of.
And would we get notified if there was a general treatment plan up on the website?
That's a good question.
Because we wouldn't contribute to it if we didn't know it was there.
Yeah, under the legislation, there are certain people that are notified, you know, people like the public advocate and the child commissioner. I don't think that GPs are directly involved in that list. But that being said, it could be something that we advertise, let's say, through the CHN. There's nothing that says under the legislation that wouldn't be possible to make it easier for GPs to be aware that one's been submitted. But I would have to triple check the mechanisms by which that happens.
Sure.
And look, just going from what Roxy was saying, it is a lot of work, and it's not something that I think I would really expect an individual clinician to be doing. It could be submitted by an individual clinician, but it's quite a bit of work. And I think so I think it's useful and something that going forward, sort of working with the health directorate around what we think would be the most useful and what would be the most helpful. I do think it's worthwhile just pointing out with the general treatment plans, it is very helpful in the sense that if there's a young person that falls under this, you won't need to put an individual treatment plan through, but you still need to go through the information and supported decision-making process as you would with an individual treatment plan. You still are required to do that. Don't think anybody wouldn't do that, but you still have to really be making sure that you're clearly documenting the information you're providing, the wishes of the young person, and that's still a requirement under a general treatment plan. You just don't have to put in the application for it. So next slide. So following the submission of an individual treatment plan or the public consultation period for a general treatment plan, the assessment committee will make a decision and notify the applicant of the outcome. So there's 3 possible outcomes of the application. So they're approved unconditionally, approved with conditions, and not approved. So our experience, going through and putting individual treatment plans is sometimes the board will come back and ask for additional information to be able to review the individual treatment plan appropriately. So that's potentially something that happens. But in terms of the outcomes, you will have those 3 options: approved unconditionally, approved with conditions, and not approved. And then you will receive that notification about why the board came to make that decision and what information and evidence is used to make the decision. This is brand new legislation. It doesn't exist anywhere else in Australia. So I do think there's a process of going through the board, clinicians putting in treatment plans to really work through the process and what's required and what's needed. So so as we go forward, I think it'll feel clearer for clinicians as we go forward and we get those decisions from the board. I think so right now it's all very new, I would say. So next slide. So you can appeal a decision. So if the application wasn't approved or you're concerned about the conditions that were approved with the treatment plan, you can request an internal review by the committee. And my understanding that because we have enough board members that would be reviewed by members of the committee that weren't involved in the original decision making. It's reviewed and then that comes back with an outcome from that review. If people are still not satisfied, then you can appeal to ACAT. And that's where, from that process, ACAT will either confirm the decision or will make recommendations to the review committee. So as Roxy was talking, there are reporting requirements under the legislation. So within 3 months of starting a approved treatment, you need to send a report to the board to say that this treatment started. So there's 3 circumstances that you would need to send a report. So that is under an approved treatment plan. So once that's come across, you've received that approval and you initiate and start that treatment, you have that period where you can then let the board know that that's started. For any urgent restricted medical treatment that's performed, that will need to be reported to the board as well. And any treatment undertaken on a person's sex characteristics that would be a restricted medical treatment if the diagnosed condition were not excluded. So that includes that list of exclusions that Roxy provided before. And again, you would have 3 months to be able to provide that report.
And so, sorry, just to jump in there, an example of that third one, because I think that's probably the trickiest to understand. If we were, performing a urethral lengthening on someone who is a prescribed person and has hypospadias, for example, that's still a reportable treatment, even though the hypospadias is an excluded condition. So just making sure that you're, I guess, across those definitions is really important to make sure that you're not missing out on those reporting requirements under the legislation. And the reporting form will be available on the ACT VSC website. It'll be like a de-identified form. You put in the treatment and the bits of information that the form asks for, and that's all that needs to be done under that section of the legislation.
So next slide, I think we'll go into a little bit more detail. So each report is de-identified, but it includes details of the reportable treatment undertaken, the date the reportable treatment started, the prescribed person's age at the time of commencement, and the particular variation in sex characteristics that the person has. And if the treatment was undertaken under a treatment plan, then it would include details of that plan. So, next slide. So, look, I just want to acknowledge that this is probably the most challenging aspect of the legislation is the criminal penalties that are applied, and sort of talking to clinicians is the one that produces the most anxiety and produces the most uncertainty. So there's 3 criminal offences under the legislation. So undertaking a restricted medical treatment, arranging an unapproved restricted medical treatment, and authorising a unapproved restricted medical treatment. The idea of having criminal penalties is really to underline the harm that has been and can be caused by undertaking treatment where informed consent has not been provided. And I think, and we'll move to the next slide. I think the penalty that would impact health practitioners is the penalty for undertaking restricted medical treatment without approval or without meeting the conditions of a treatment plan. So that is a maximum penalty of 2 years imprisonment and 200 penalty points. So I had to learn what a penalty point was. So it's equivalent to a specific amount of money. So one penalty point is $160. And so for 200 penalty points, that would be $32,000 for an individual, and for corporations it's more. So one penalty point is $810, and so that would be $162,000 for the corporation. So it's significant, and for the second offence, there is a penalty for arranging or authorising an unapproved restricted medical treatment, and it's a maximum penalty of 100 penalty units and 1 year's imprisonment. Now, this is the penalty that can, where parents can be caught up in as a criminal penalty in it. So, as I said, this is brand new legislation. There's always lots of questions. And I think it's really important to follow your normal processes. For example, your normal process for assessing GILEC competency is appropriate in this. The difference is, what I've found in doing this and putting in individual treatment plans is that it does change how you need to document what you're doing. So you really need to document your decision making about whether somebody sits under the legislation or not, whether this is a restricted medical treatment or not. And you need to document quite clearly what information you've provided, how you've supported the decision making with the parents and the young person, and their wishes. So the things that sort of going forward is important to be able to document and have there, and to be able to justify decisions that you've made. I do think it'll be important to consult with other colleagues and specialists. Even today, that sort of question of does this fit, doesn't it? And it really has to fit the legislative definitions, not necessarily the traditional definitions of what we would consider variation in sex characteristics. So that's been pretty evident in going through this process.
Alyssa, can I just interrupt and ask a question? So with the second one, arranging a procedure, does that include GPs making referrals?
So this really, and Roxy, please let me know if I'm wrong, this is really where the parent takes the young person out of state and goes and finds somebody who will provide the treatment to that young person. It doesn't, my understanding is it doesn't relate to GP referring somebody for treatment. So even if, say, a paediatric endocrinologist wants a second opinion, they can refer to a paediatrician interstate, but it's about the actual then that treatment being undertaken and undertaking it with the knowledge that it's restricted treatment. So it's the parent knowing that in ACT, this is a restricted treatment, and I'm going to go find somebody who isn't aware of the legislation and seek that treatment.
Yeah.
Would that be correct, Roxy?
Yeah. So I guess that second dot point there, arranging, that's if, the parent pops across the border, knowing that this legislation exists in the ACT. I suppose the way that it works in, these jurisdictional laws is that there's not a way that the ACT laws can necessarily apply to a doctor in New South Wales. So it's more about, combating that, I suppose, as a way of the parents, if they, when it says authorizing, I guess that's giving consent for the child to undergo whatever would be considered a restricted treatment in the ACT. That's where those two are, not necessarily relevant to the GP. You could write a referral, certainly, to New South Wales, and there would be some ethical issues with that if you knew that there were, it was illegal in the ACT and you weren't knowingly writing that referral to New South Wales. But the penalty, I suppose, would come to the parent who then gives that final consent. But yeah, that would be a very grey area, and like I said, that ethical consideration if you knew and you wrote the referral. Yes. Sorry, I'll just jump back to here.
No worries. So there are 2 contact points. So we'll talk a little bit about, there is a new variation sex characteristics psychosocial support service. So that's the CHS service. And we also have the variation sex characteristics team within the health directorate that Roxy sits with, that provides information. So both of those are available, but providing sort of slightly different types of support and information. And I think Roxy, on the website, you've got an email address that people can contact. And,
yes. Yeah, and I popped that at the end as well. Yeah. And it looks like I'm the only person in this team. That's definitely not true. We've got a whole slew of people working to get this.
Working hard.
Yeah.
So, yep. So I did want to talk a little bit about the variation sex characteristics psychosocial support unit. So this legislation sits under a broader health reform, and one of the things is providing psychosocial support to children with a variation sex characteristic in their family. So yes, it's sort of supporting decision making. That's one of the reasons why I should refer to the psychosocial support unit, but it is also helping them adjust to diagnosis, being able to support, if there's distress, provide further assessment. So in this service, we have a care coordinator, we have a social worker, and we have a clinical psychologist. So it is a service you can refer to if you've got particular concerns around capacity to consent and you feel that you need additional support and additional assessment in that. And so it is for young people up to the age of 17. And this is a service that's not just for CHS clinicians. GPs can refer to it, and other private clinicians can refer to this service. It's also really helpful, very useful, particularly when we're talking about what information is provided and support is provided to the young person and their families. So being aware of intersex peer-run services like Agenda. The Intersex Human Rights Australia has a fantastic service, Interlink, which is that people can be referred to, and Intersex Peer Support Australia are all services that can provide that additional information and support to families. And there are some specific condition-specific support services like the Turner Syndrome Association, the CAH Support Group Australia, the MRKA Australia. So part of that provision of information is being able to link in families with these types of supports. So thank you, everybody. We've gone through this. So as you can see, we have gone through the scope and rationale of the legislation, talked a bit about the processes that are involved in the legislation, and talked a bit about the legal obligations and expectations, and where to access and refer to additional support. So there's a link to the website there that has quite a bit of information, has the individual treatment plan forms, so both for children and both for guardianship, and the general treatment plans as well. And we've got the email address there to be able to contact Roxy's team to be able to ask more information. So,
and we're more than happy if there's things you're not sure about or things that aren't clear. That's why we exist as a subsection of the LGBTQIA+ team to help answer those questions and help you understand. Do I not maybe require a form?
Yeah. And that team's been really helpful to us as the psychosocial service to really understand understand the legislation and to be able to ask those questions. So certainly do recommend, if you've got some questions, to put it towards, and they'll assist where they can.
And I think, Leonie, that even that's quite a wordy link there. I think that's on the Health Pathways website as well, to directly link to our VSC ACT Health
just
website.
tell you, I'm just looking at the website now. I think, yeah, contact the service. Yeah, I think it is.
Okay.
Yeah. So, thank you so much to Roxy, Alyssa, and Michael. There's so much to learn there, and I think that possibly what this will do is put it in people's minds that if they have a question, if something's coming up that seems a bit ambiguous or unclear, that they really need to look up and see where the legislation stands and what kind of supports they can give their patient. And it's great to have all those resources for people to look back on, and also to have such easy access to both you, Alyssa, and to Roxy for questions. So I'll just put it out there. If anyone's got any other questions for the night, type them in now. But Roxy and Alyssa have very kindly offered their emails and their contact details if you have questions after tonight's webinar. And just a reminder, so please fill in the evaluation survey, and you've got 1.5 hours of educational activities for your CPD points for 2024. So it's looking like we've exhausted people with questions. So I just wanted to say thank you very much again for your wonderful presentations and your kind of generosity with your knowledge. And just let everyone know that the webinar will be put up on the Capital Health Network YouTube page in a couple of weeks if people need to look at it again, or if they've been talking to other clinicians and they've got questions. So please share it with your networks. And thank you very much for tonight, and I'll say good night.